The next step is going to be, now we have the targeting, and I think we saw a lot of challenges. I think Meng, really, I mean, that was just a tough case. This was very, very, we saw what happens when the X-ray is not perfect. We adjusted that, adjusted different angles and everything. I mean, this was like real. I mean, except for there was no bleeding. That was the only thing. And now we go there, now you go in there and you have to create that space. And that can be really challenging. Another thing is, like, when we do open surgery, it's like eating a steak, right? But now nobody in here eats a steak via the endoscope, right? Or anybody? I mean, or if you do, then don't admit it. That would be sick. Okay, you good?
I'm good. I'm ready to go.
All right, soft tissue it is.
All right. Hi everybody. Nathaniel Brooks. I'm a neurosurgeon. Mostly do spine at the University of Wisconsin. And I'd really like to thank the course organizers for inviting me back. I think this is a wonderful course. Having picked this up many years ago, I know that you kind of feel like you're all alone out there, and it's great to see everybody getting together and learning from each other, and then teaching the next generation, which I'm sure will be even better than us. I really do like the organization of this particular demo / didactics. I think it will really give you guys a better understanding, even though sometimes you're seeing us work through some challenging situations. You can see kind of how we do it and what we're thinking along the way. The co-demonstrators are going to be Dr. Mahan, Dr. Konakondia, and Dr. Yoon, and we're going to take you through soft tissue manipulation. Of course, when you're thinking about doing endoscopy, this is a precision tool and a platform, as we discussed earlier. And there's multiple things that you're doing with this platform. You're, of course, targeting, which we talked about. You're doing dissection. You're doing retraction, you're doing hemostasis, and then you're modifying tissue, which can be soft tissue or bone, and then, of course, whatever pathology. Targeting certainly can't be undervalued. This is actually, because it's a precision tool, you can't expect to just kind of show up in a random location and then get the work done in an efficient manner. You have to be where you have to aim exactly where you want to go. And that's where your fluoroscopic skills or navigation really come in handy. And I'm sure we're going to learn a lot more about navigation and robotics, which are enabling technologies, which in such as a scoliosis case would make things look a lot easier. And so that's really important. Once you've done your targeting, you're using the targeting to essentially get yourself to the location, and then there's a couple more steps to make sure you're in the right spot. One is tactile. You can just feel the bony prominences, the anatomy, the soft tissue of the ligamentum flavum, or if you're doing a transforaminal view, you can feel the facet joints, you can feel the transverse processes. Those things can give you comfort that you're in the right spot. So you can use that tactile feedback, and that, again, is something that you build over time. You get really used to the fact that, I'm fairly confident I'm in the right spot, even though the fluoro showed you that. You have that secondary understanding. And then visual feedback is the final step, where once you clear soft tissue, you can actually see anatomical landmarks and get yourself to the point where you're confident this is where you need to be. And then once you get under the scope, of course, you're dealing with microanatomy. For those of you who have not done this before, you really aren't used to how interesting and good the tissues look, right? So you're typically not seeing the ligamentum flavum this up close. You're not seeing the epidural space in this manner. In an open case or even an MIS case, typically you kind of dissect through the ligamentum flavum somewhat blindly, in fact. And so it's actually with the endoscope much more confusing, because you're actually looking at these tissues and seeing these tissues in a different way, which can slow you down in some cases. And then you have to get used to how things look through the endoscope. Most scopes that we use are going to have an angulated camera, often about 25 degrees or 30 degrees, depending on the type of scope, and that can change the view about how your tools come into the working into your view, and then also you have to learn about how you can rotate the scope to see different things, and you can see around your tools, and that actually is another skill that you develop. And eventually get into tissue dissection. You get into the epidural space. You're using various tools to mobilize. In this case, a nerve root, epidural fat over a disc.
So one thing to point out in this video, did everybody see, maybe we can start it again. So pay attention to what happens to the radiofrequency probe. Because in the videos, you see how it kind of goes out at the same time. So, what he's doing, he's isolating the lateral movement. You see that the shaft goes out there? But you isolate that off-axis movement, which is really difficult because you have to push the trigger. At the same time, you pull out, then you have an isolated lateral movement. There's nothing else in the endoscope that allows you that lateral movement. And you can see that really nice on that video.
Yeah, that tool, and then there are some articulating burrs that function like that, but those are nice tools. And you see with this kind of learning these skills of tissue dissection, it will allow you to manipulate tissue in many instances. Okay, so then the other thing is you can move the entire endoscope and working cannula as a unit. I show this video not for you to watch the actual discectomy, but watch the hands. Okay. There's so much movement happening outside the patient, and you have to get used to how that will function deep inside the patient. So it really is amazing. This is just a simple discectomy, but you watch how much movement there is, and how coordinated all that work is done in that very confined space. And then hemostasis is critical for visualization, for defining anatomy. And so you really want to be able to understand and do this. Unfortunately, in cadavers, you don't get that effect, which sometimes can give you this false sense of security when you start your first cases. This is really a critical component to being able to see well.
So on this video, you're using the probe and you're finding bleeding. Are you using continuous bipolar action? Or are you kind of buzzing intermittently? And how would you?
I do it intermittently, yeah. and the probe functions somewhat like a finger. So I'm actually kind of moving around, pushing, and seeing where the bleeding starts to stop, so that you can find the bleeding point and then cauterize. So yeah, it's not a continuous thing.
And then, when you often, for the audience, when you put your probe on the source of bleeding, before you even turn the buzzing out, it will clear out because of the constant irrigation. And then as you continue to effectively use the bipolar, it will help clear out or stop the bleeding, and your screen will go from being this hazy, as you can see on the video, this hazy color, to this very clean, pristine kind of view, and that's how you know you had a good coagulation.
Yeah, and in this video, I'm actually not only using cautery, but I also am carefully, under direct visualization, rotating the working cannula, because sometimes that will compress those epidural veins, or just isolate them so you can see better. So all of those things are kind of happening at once, and you'll develop those skills as you go. And then we work on different things that we do with retraction. I made this video so we could simplify what you're doing. So you can move the scope and sweep tissues, which is what we're showing here. Dr. Young, developed the beveled cannula to allow you to do a lot of these things, which I think is huge. I think utilizing the shape of that cannula really affects how you work. Okay, so in this case, we're using a rotation of the cannula to protect whatever structure we want to, and then we can work through the endoscope and then work through our working channel to manipulate other tissues or take out disc material or whatever we need to do. So there's a lot of these kind of movements that are happening. They can sometimes be hard to see on the videos because you're not really identifying them through the camera. It's how the hands move outside of the patient that actually does a lot of this work. And this would be an example of how it would look inside during a case. We rotated that cannula to protect the nerve there in this instance. there we see the nerve has been moved medially, and then we just have disc material. So that's an option to work, and sometimes you use that, sometimes you don't, just like you would do for an open case. You don't want to over-retract structures if you think you're going to damage them, so that those are things that you, of course, skills that you probably already have, they're just miniaturized. And then other tissue modification tools, we have the micro punch, or what sometimes is called a scissor, things that look like Kerrisons or bone punches. All right, fast forward this a little bit. Pituitaries.
And for the audience, when you get into the lab, take time to look at the different tools for and learn the tools, because everyone has a different way of doing things, right? And then you'll notice that there's different size pituitaries, different size Kerrisons, and depending on what scope and what trajectory or approach you're taking, you may want to use a different set of instruments.
And then I know this isn't the focus of this talk, but of course, removing bone is another type of tissue modification, and that's the drilling thing, which we'll learn about later. So with that, we will start with our, any questions about that before we move on? Please, go ahead. Microphone, if we would.
I'll just speak up. Can you comment on the adjuvant use of epi in your irrigation fluid, flow seal, and other materials down the scope channel for hemostasis, other than just the bipolar?
So I just use normal saline, although I know others use epi or TXA, other adjuncts. I will use, I don't use flow seal per se, but I use gel foam slurry, just because it's less expensive. And you think about the working cannula as like a big giant needle, okay? So you can just basically inject some in there, tamp it down a little bit with one of your tissue dilators and kind of hold pressure for a little while if need be. I don't have to do that often, but when you do have to do it, of course, you're in a difficult case to begin with. And then, of course, there's bone bleeders. Those can be challenging to deal with, and sometimes can be dealt with cauteries, sometimes need diamond burrs, sometimes bone wax is another adjunct that we use. So.
How do you get the bone wax down there?
I typically will have to pull the whole endoscope out, put the bone wax on the end of like a dissector or something like that, and then you can reapply the bone wax. So in much the same way, these are these new concepts that we're coming up with. Like either you can place the tool in backwards with the bone wax on it, or you can just So these are some ways that you can use it. You prefer not to, right? But
working channel, it always clots everything.
Yeah, you don't want to put it right down the working channel because it will just create a big mess for you, and so you kind of end up utilizing the entire endoscope as a tool, a tool delivery device. Ray, you have a comment?
Yeah, so sometimes I'll put the bone wax on the drill bit and just put it down and turn it on and like smear it.
Yeah, that's a good thing because it's good shape. It's a good shape for that too. Yeah, so these are all these smear.
I would recommend it against using epi or TXA in the irrigation fluid. Because epi, if you get into the venous system, it's increase the blood pressure, so it makes the bleeding worse. And the TXA, actually, don't use in the irrigation fluid because, God forbid, if you have a dural tear and it gets into the dural space, it causes generalized seizure.
Right. Yeah. So you've got these things.
Reported a case for the patient who underwent hip replacement. They did epidural anesthesia, but somehow the needle, they used TXA and the needle got into the dural space, to the dural space. And the patient had a generalized seizure. And
perfect. Okay, so now, thank you very much. We're going to move to the demo just for the interest of time. And so our first demo is going to come from Dr. Mahan. He's going to show us the interlaminar approach and soft tissue manipulation, okay? Mark, take it away.
Okay, fantastic. So just to go over, we have, if you'll swap to the X-ray, we chose a location that's going to land us on the top of the the caudal side of the cranial lamina or the L4 lamina. That would be approach for stenosis. A little bit further south for a disc. All right. Now, what I'll do, if you swap to the screen, see my hand, once I've created my localization, I'll put a little imprint on the skin, which tells me how big I want to make my skin incision, because it's particularly important that you have a tight skin incision around your tube, so that if you make it too big, water is going to flow around your tube and not outside the working cannula. So down here through the skin, through the fascia, it's most important not only to keep that skin incision big, but also to undermine the fascia rostrocaudally, so that you have freedom to operate in that space. The next thing is the first step of your dilation is you want to land on the lamina. So that I'm going to exaggerate the angle here. If you can see my hand, I'm going to start off with the first step of dilation onto the lamina, so that especially in the deep patient, you want to be able to feel all the way down there, know it. I will have my MRI up on the screen so I can say like, oh, I need to go about approximately 6 centimeters, 8 centimeters down to the lamina, so I can also approximate, hold my tube. I know exactly how far it's going to take to get to the lamina. Land on the lamina, then work to the same angle as your fluoroscope. Then at that, because at the angle that your fluoroscope is to optimize that the interlaminar window, now you can start to dissect out. I'm going to feel the underside of the lamina, feel the spinous process come out, and then mobilize the soft tissue, create a little working space so that I can rapidly move to the next step.
So, Mark, you call this, I believe for your trainees, you call this the zone of confusion.
I call this the zone of confusion. You want to create a little space, because your goal in that step is to mobilize the multifidus muscle along its trajectory. The multifidus inserts on the spinous process lamina and then wraps around the underside of the lamina to the mammillary process. And so by doing that sweeping dissection, you naturally move the fibers in the line that they exist. And again, I'm keeping myself relatively cognizant of the approach trajectory that I've selected, meaning that I know that my hands are going to be held at the same degree that of tilt that my fluoroscope is at. I'm going to maintain my fingers at that level, stay on the bone, have downward pressure, and that's it. We just want a nice quick dissection, create muscle dissection, then we can move to the endoscope. You can move back the fluoroscope, and can we drop the table?
All right, so Mark, I really want you to describe right now. We see nothing, right? So what is guiding you right now? And let's say, let's say you kind of see this for the next half an hour. How do you get to the target area, to your bony anatomy?
Correct. This is what I call the zone of confusion, because the first thing you see is muscle fiber, fat tissue. The two things that are going to keep it most sane for you is if you are in a interlaminar window that you visualized on your X-ray that you're going to be right against to a bony anatomy, you can sweep up, find the bone. You can see that if you can visualize my hand, it's rising up slightly with coming over the edge of the lamina, so that makes sense to you.
So do you do that based on what you see or based on
what I'm feeling and knowing that kinesthetically that when I'm moving cranially, my hand's dropping caudally, and so I know that when I'm going to find the bone edge, I've used my X-ray to tell me what I should expect to see. And if I know that I'm going to be landing on bone edge on my X-ray, or how far I am, how far I'm going to have to work to that. So again, the X-ray informs your mind's eye about what you'll need to see next. And as Christoph is astutely pointing out, there's a lot of palpations, a lot of tactile feed. The first thing is the fluoroscope to tell you where you are. The second is the palpation to identify osseous anatomy, if you choose to find the osseous anatomy. Yes. And then once you've palpated those targets or the osseous anatomy, is to clean it up, make sure that it's nice and clear.
So you can see, Mark, I don't know what you do, but for training people here right now, I really find this is one of the hardest things to train, because you start looking at these amazing, like you said, confusing muscle fibers, right?
Well,
how do you prevent somebody from looking at these confusing muscle fibers and get confused, right? And still trust your palpation at this point. So how do you teach that?
It's exactly what I'm going to go into. So these are the stranded muscles, the multifidus that you see. It's beautiful. This is straightforward. I know that this is going to be multifidus muscle. In the alive patient, you're going to see a distinguishing feature of muscle versus tendon, and you want to make sure that you pass through that tendinous border. Do you see that this? Now we're seeing more muscle as opposed to if you back up, you see a lot more tendon up here. If you are not seeing muscle fibers and fat, you're not deep enough because the layer just immediately superficial to the interlaminar window is going to be filled with fat and a little bit of muscle. So palpating the bone edge right there, moving through, and the moving technique for
Mark,
me.
this is great. We just in the interest of time, can you get us down to some bone and then onto the ligamentum flavum, just so we can.
The tissue dissection. I'll move faster if I.
I know. I'm just going to let just so we can get to the next two demos.
So
You're doing great. Thank you.
The tissue dissection technique is using the tip of the working tube to move through the muscle. You want to just quickly move it off with the tip of the dissector, right? So I'm using that spinning technique to really move the muscle, and then soft tissue coagulation, removing this tissue, coming out, sweeping out. In the interlaminar space, depending on the pathology that you're seeking to treat, you're going to find out to go down to the facet capsule, identify that anatomy. What we're here is to really focus on some of the soft tissue handling. It's not so much always that I have to find which anatomy, because it's dependent on the case. So if you want to find spinous process is going to be there. It's going to be rising up dorsally. Once we've got this tissue moved off, we can keep, again, serially advancing as we go through this tissue, and then switching. So now we'll see the facet capsule here. I like seeing the facet capsule because if I want to find my caudal lamina, it's going to be at the edge of the facet capsule. Removing some of the soft tissue is very easy, but again, if you're thinking about soft tissue, I just want to disconnect it, go through it, and move the tissue caudally so that I can then look at my interlaminar space, because I don't really feel like it's not like you're moving through like on a tubular case where you're trying to actually resect the bone. Resect the tissue. I just want to move it away. Now you see the caudal lamina. It looks like somebody who may have been here before because we're already mobilizing the ligamentum flavum, and you can see epidural fat coming up through the ligamentum flavum. And at that point, you can start to resect it with Kerrison or other tools.
So the main tool that you use here is going to be cautery and pituitary or grasper.
Yeah.
And the pituitary it pulls but does not cut. So that's a nice tool here because you can kind of both probe and palpate and remove tissue. And then, of course, you want to control any bleeding and until you move into the next step, which will be the ligamentum flavum. Which hopefully we have enough to resect.
So some other important key steps too is that once you've come to, you can see the osseous anatomy. This is the cranial side of the caudal lamina. You can see that. You would see that this is the interspinal muscle here between the spinous processes, midline raphe of the ligamentum flavum. There's an important structure here. So this band right here, may I have the through cut, is where the multifidus comes to the mammillary process, as I mentioned. And to get to the SAP, you need to cut through this, because once you cut through this, then you can get down to your facet joint. So like if you're doing a discectomy that you really want to see into the SAP, this is a really key landmark that I can start to pull up the ligamentum flavum at this corner if I want to get down to my SAP and work in this space too.
So this is just caudal to the inferior articulating process as you drop off the edge. Is that correct?
Correct. And so one thing to be aware of is oftentimes you'll have bulging synovium here that can look a little bit like nerve root, even though you would never expect the nerve root to be above a lamina. But there'll be this white stuff. It's frondy. It has a unique vascular pattern. But this gets you into that space. So now you can remove all of this ligamentum flavum Harrison, please. Between the top of the lamina and there. Oftentimes, if we don't already have a midline defect, we want to go through the ligamentum flavum serially. And what I personally like to do is put a lot of downward pressure on the working tube so I can tension the fibers of the ligamentum flavum, and then you cut through it with a through cut. And the technique is to push down, pull up the tissue, cut through, right?
Mark, would you just pause the tool and bring the camera back just a little bit and just rotate the tool so they can see what it looks like. So when you close it, go ahead and close it, you can see that the lower jaw is blunt and sticks out a little bit more than the cutting jaw. And so you can use that to dissect and then get a piece of tissue in between the cutting surface. But that can actually help to protect you as you're thinking about the deeper structures. I think a lot of people who see this, who are not comfortable with endoscopic procedures, usually see this part as a blind procedure, but I think it's actually very well visualized. It's just because the shape of the tool is part of the protection.
Hey, Mark, one other nice thing you can do there is you can put your bevel on there and put it under tension a little bit. Would you mind just demonstrating that for the audience? Put your bevel.
So tension is very critical at this point here to be able to.
You guys see how the tissue kind of like pulls and how you.
So Mark, if you don't mind, I'm going to show your video just because it has a nice view with the dura and everything. So would we switch back to the talk for a moment? See if I can get this to work. So if you watch on the video, you can see that doing that same kind of thing, debulking the ligamentum flavum, and also putting some tension. We at least those of us that do this often can appreciate that manipulating the working cannula has allowed us to get a little bit more tension on that ligament.
Okay.
And
so
actually,
this is the point where
that video. I just want to get to that. I'm sorry, Mark. It's such a great video. I don't want him to miss out. I'm going to fast forward it. There you go. You can see just as it really thinned out, you can see that he popped through there. And of course, the irrigation is going to push the dura back. And so at that point, you actually still can continue deeper, knowing that the dura is actually compressed. Perfect. Keep going, Mark. Sorry. Thanks. We can switch now back to Mark.
So once you've reached the inferior articulating process at the level above, you're going to have the SAP down here. This is where you run into the SAP. You can't open up any further. Removing tissue here gives you a little further lateral access. So if you're working on a disc, this is the tissue you need to remove to get as far lateral as you possibly can so that you can enter into the...
And I've always thought of this as like a miniaturized version of what you do anyway. So whenever you're doing exposure, that's...
Everybody in the audience, take a look at his endoscope. The endoscope looks towards him, right? And the tool is, at least when he starts working with the tool, see, when he engages the tool, it's 90 degrees so that he can see it. So looking towards himself right now, using those 15 degrees, and using the Kerrison to really visualize what you're doing. So just take a look at that.
Yeah, and so that really amplifies your ability to remove tissue and visualize, learning those skills. Mark, that was excellent. Thank you very much. We're going to move to the transforaminal view and with Sanjay. So Sanjay, are you able to?
We just have to get the docking out real quick first.
Okay, all right. Any other questions while we're...
Just regular transforaminal.
Any questions from the audience while we're transitioning?
So I think one thing that some surgeons dock direct. So that spot. Yeah. So that was a great presentation, and it's really it was nice to see that Mark goes to that area right next to the SAP directly and then bites the ligamentum flavum there. So there are some surgeons that dock their working channel there initially. So I don't know if anybody has any advice about when, because I dock on the inferior lamina, But I know
You're
some
talking about
people-
the junction of the IAP and SAP?
Yeah, exactly. So some
yeah.
surgeons dock right on there. So what are some benefits to people that are doing it, and why don't we do it more frequently, I guess, for a situation like that where that's the point you're looking for anyways?
I think if you need to, so if you're at the L5S1 level, you may not need to remove much bone at that level. So it's an added step. But once you get higher in the spine, interlaminar locations will require sometimes resection of the portion of the medial facet joint to get a good decompression, access, and exposure. And so as you develop your skills, get more comfortable with drilling, then you can utilize that to get access and get exposure. And I think that's important. If you start, it just improves the efficiency. If you start at the caudal aspect of the IAP and then drill rostrally, you're kind of starting where you need to start, ending where you need to end, without kind of bouncing around in between. That's kind of been my experience. But you could also do it the opposite direction, just identifying that as the main landmarks. So I'd love to hear other thoughts, but that's always been it's easy to palpate as well, so I like that.
So that starting point can sometimes be difficult to find if you have a significantly collapsed disc with shingled lamina, because basically the trailing edge of the cranial lamina is covering that place. So the more consistent place to find is the spinal laminar junction. That's kind of a good place to start, or laminofasciate junction, either of those. So, and this all depends on, people will use different techniques for big interlaminar windows versus small interlaminar windows.
Correct.
And like, I prefer to do the same thing every time, no matter what. That works with all of them. That's why I go to the trailing edge of the cranial lamina at the kind of spinal laminar junction.
And I think that what this discussion really brings home the point of is actually how sophisticated our discussion is of these tiny little landmarks. That's another thing you will pick up over time, is you're like, wow, this is an important landmark. But if you were looking at an open exposure, you'd be like, I mean, what is this? This is like nobody would think about it. So that's a real critical thing, is you get used to these discussions, and you'll hear more as we go through the transforaminal in different landmarks there as well. So. Sanjay, are you ready to go?
Yep,
Okay.
we're docked. So,
Awesome.
What everyone's been saying before, Christoph's book really just explains this very nicely and succinctly. Imaging, palpation, and then visualization. Tissue dissection starts from palpation, right? So right now, if we get a bird's eye view of this model, we're docked transforaminally. What I want to do is dock this tubular retractor flat on the annulus. So I'm going to dock on this annulus and visually see that arch as I turn, right? So that part of getting that extra tissue out of the way is super critical to skipping a bunch of steps here. So
what's the arch called? I'm sorry.
It depends on who wants to call it whatever they want.
What we describe anatomically, what makes up that arch?
Oh, okay. Yeah, it's the pedicle and the ventral portion of the SAP. So
okay.
So keep in mind, we dock backwards, right? So I'm pointing away from me, but my bevel is there. You can see most of the bevel because I purposely put it backwards. So under direct visualization, I can turn, and you'll slowly start seeing that arch come into view. So you see this pedicle arching over to the ventral portion of the SAP. Does everyone see that there? So I'm going to try to point to it here. May I have the bipolar, please? It's a little bit unfortunate, we have a better view here. It's not projecting well to the bigger screen, but we'll try our best to kind of clean this up. So immediately over here, the bipolar actually shrinks tissue. So if you have this fat in your way.
Sanjay, back the camera up just a tad bit, if you would.
Can you take a quick minute to just orient the crowd to what's medial, cranial, lateral? So
12 o'clock is medial. This is where the ventral portion of the SAP is. Cranial is right here towards 9 o'clock or 8:30. And then the caudal is right here at 3 o'clock, and towards me is going to be 6 o'clock.
Would you mind rotating the scope back to neutral? I think it's mildly.
You're talking about
have it rotated just a
talking
little
about
bit.
this?
Yeah, you have it kind
Oh,
of
you want
rotated.
this?
Yeah, like that, yeah. And then rotate the bevel just a little bit more, and then I can point out the landmarks here. So,
Yeah, so part of it is uncovering this slowly. So this is all purposefully done, right? So
yeah. So head is this direction, feet this direction, medial is the top of
okay,
the screen.
so if you want
lateral
to see that,
bottom.
okay.
And then SAP is up here, and then pedicle is going to be to the right of the screen.
So ventral portion of the SAP coming down to the pedicle right here, okay? So if you identify this pedicle here, you can follow that down to the annulus, okay? And this right here is going to be where the annulus is. So a lot of this dissection is pretty much done if you are able to palpate, right? Not skip over that step, palpate that bone. So I'm feeling that I'm in that foramen, and as I'm turning this, it wants to watermelon seed out of that foramen, so I have a little bit of downward pressure, and I'm rotating all these tissues out of the way. So already I'm seeing fat of the epidural space.
Right here.
This is annulus right here. This is pedicle going into
there.
the SAP. Does everyone get that? So let's take a picture right here. Take a shot right there, please.
I think we need to get
So on that AP, you can see I'm entering into the canal, which is not surprising, right? That's exactly where I thought I was. And all these pictures are supposed to be confirmatory, right? You're supposed to think where that picture is going to show you, take a picture, and make sure that it confirms it, right? You're not doing any investigation after you take the picture, right? So if this is the pedicle, I know that going into this space, we'll go medial and to the pedicle into the canal. Take a picture. So that's exactly where I thought I was going to be, and that confirms it. So again, confirmatory x-rays. So you can see that black hole over there. That's going to leave me in my epidural space. So if there was a paracentral disc herniation or a foraminal disc herniation, it's right in this spot. Okay, may I have a pituitary, please? So again, disc. And if I want to go parallel to this, remember, when you do a transforaminal approach, you're coming in a craniocaudal trajectory. So if you really want to orient yourself and go parallel to the disc, this gets you an idea of where you are. So I just drop my hand to come straight down from left to right, and now I'm parallel to this disc space, okay? So this is a disc space right here. You can see this nice little white bulge of annulus right here. Top, bottom,
towards the
top,
bottom of the screen
bottom, pedicle, SAP, right? And you can actually see some ligamentum flavum here that's ventral to this SAP right here. So if we use the drill, we would be able to uncover that SAP, but I'll leave that for the other guys to do. Again, epidural fat there. May I have
Sanjay,
pituitary, please?
would you show us removing some of that epidural fat? I know that was a critical thing.
Someone's talking, I can't hear. Are you?
Sanjay, would you show us, just remove some of that epidural fat? I think you
You want to see
mentioned that.
the dura? Is that what you're asking?
If you just remove a little bit more epidural fat, I think that would be nice for people to see there.
Okay.
Yeah.
So right now I was just picking at annulus. If you want to remove some of this epidural fat, we do this. And remember, fat should come super easy, and if you have resistance, let go, right? Don't keep pulling. Okay. So remove that epidural fat, and we can start seeing, again, the free fat in the epidural space. Again, there's two ways to get more medial. You can either take some bone dorsally, or you can go ventrally by taking some of this annulus, right? You just need to create more space, whether it's more ventral or more dorsal. So as I take this annulus off, again, if there's a disc herniation here, it's exactly where you want to be, and this is the disc, okay? So may I have a bipolar, please?
John,
So I'll
did you have a
bipolar
comment?
some of these wisps down so we can get a better view of the canal. Any questions?
Well, just a comment, Sanjay. When you're done with that, can you just demonstrate how you would use the kerosene to maybe get a better view of some of removing that ligamentum flavum, kind of showing, and then we can see your hands working 90 degrees to the kerosene.
Yeah, okay, so I typically don't use the kerosene for that, but we can show you how that kerosene would be used. It's always tough to get these angles because remember, these are angled scopes, right? So, 30, 35 degrees, and your kerosene is effectively straight. So you really have to do some maneuvering and tilting to get there. So, if that's a ligamentum flavum, I have to really sort of tilt down. The other trick to using kerosenes is, you see how it's super open? I like to close it all the way, almost closed, so when I get to the place I want to be, I'm ready to make that maneuver. okay? So if you go to the place where you need to go and it was tough to get there, remember, when you close it, you're hitting all this facet. It's really like tough to make that big move. So close it almost till you're ready to use it, get onto the ligamentum flavum, take a bite. So that's how you would do that.
I think that's great, and it's also it's excellent for everybody to see how much he's moving his hands, right? So
Yeah.
you really have to get used to the idea that you're manipulating the entire scope as you work. It's not you're not locked into one position, which can
Yeah.
sometimes be challenging for people that use tubular retractor systems.
Pituitary, please.
Yeah.
And the important thing to, any endoscopic procedure, it's super dynamic, right? That's the advantage. But the trouble you can get to is that, nothing is attached to the table, right? So you can go and travel in, a lot of different places by very small maneuvers, right? So
And
if you have, go ahead.
If you get disoriented, just take another fluoro shot. I mean, that's critical.
Yeah, and remember that carrot is at 6 o'clock, and this tail is always towards you. So if you want to just get oriented, if you're like turning around too much, and if you always want to get back to home base, you go straight, parallel to the disc space, 6 o'clock, the tail towards you, so 12 o'clock is away from you, and that is going to be your bone again, SAP, and then just follow your landmarks again.
And then the exiting nerve root, what are your thoughts on protecting that?
So it really depends, again, patient-specific and pathology-specific, right? So if you're in Kamin's triangle and has a big Kamin's triangle and you're going for a paracentral soft disc or a central disc, I don't even want to see it, right? So if you're doing a far lateral disc or maybe a foraminal disc and it's pushing against the DRG of the exiting nerve root, you can you can look for it, or you probably should in those cases. So you have to, it's a little bit harder to see the traversing nerve root because it's like sort of advanced techniques here, but because you're working backwards, right? You want to leverage that scope to look around corners. So we can find it, but if you want to, let's see. So if we turn that over here.
Yeah, we don't necessarily need to see it. I just wanted to hear your thoughts on how you try to protect it.
Let me see a bipolar.
Yeah.
So now I'm looking backwards. So 12 o'clock on the screen is almost like a little bit cranial. Here, look, there's actually a little disc herniation coming out, like lateral.
Yeah.
So the way I try to find this exiting nerve root is to follow the level of the annulus, right? So if this is the disc, I want to stay right on it and sweep up and down in order to sort of uncover that. But remember, this fat here is going to be like axilla of your exiting nerve root. So if you follow that, you could also find it. Another way to find that exiting nerve root is to find midline dura, right? Again, that ligamentum flavum is hiding it. But if you find midline dura or traversing nerve root, you can follow that up to the axilla and then follow it back.
Yeah, and it's often covered up in muscle fibers in that location, so it is pretty well camouflaged. But I think an important point also is to just not angle the scope too aggressively up into the foramen, because there's a lot of leverage with the scope, and so you can easily compress the DRG.
And this right here is super important to see, right? So there's a lot of stuff, a lot of layers here that we're not used to seeing because we're millimeters away from the pathology and the anatomy. So when you look at this effectively, this macro photograph of all the anatomy we know, you have to trust the fat, right? So if you see a bunch of tissue and behind that tissue there's fat, there's no way that tissue is going to be dura, because unless there's a pathology, there's no fat in the intradural space. So you should be confident and remove that confidently, if that makes sense.
Perfect. Thank you very much. That was great demonstration. We're gonna, any questions? One quick question maybe, and then we'll move on to Dr. Yoon. Okay.
And one thing to notice also is like when he's manipulating the tool in his right hand, he doesn't, if he wants to go right or left, he's using his left hand to direct it right and left and not bending the tool in his right hand. So that's one thing that you're going to have to, and he's not also just bending the endoscope, he's bending and moving the actual cannula. You don't want to bend the fiber optics. You also don't want to bend your tools. So, using your left hand and your right hand in conjunction is important.
This anatomy is also key and critical. This is the most important part, is where you're going to see that he already briefly saw a vein, is the first thing you generally will encounter in the foramen when you're heading medially. So you're going to go, he's removing the disc. First thing is those lateral veins that everyone encounters when they're doing a fusion. Once you've encountered that, that's when you're going to see the nerve root, which is a root sleeve. It's not a root, it's a sleeve. So sometimes that sleeve will fold on itself under the pressure of the irrigation. So you may only see a little bit of a folded sleeve of dura, okay? And then once you've taken out the disc, the root sleeve of the traversing nerve root is going to fall into view. You will not see the root sleeve when you first encounter it because of the disc herniation, right? So you have to have that in your mind. You're like, I have to remove all the disc until I see that root sleeve. And in a second, he's going to just look up at it. And
Mark, this is exactly what you're talking about. You see this little vein there?
Yeah.
Can you move the scope just a little bit higher? There you go. Yeah.
This little vein right here.
Drop
That's
your
not
hand.
dura. That's not traversing nerve. You see this?
We can't see that.
Drop your hands.
Pull your scope back.
Yeah. We're just not quite seeing it. There we go.
Yeah.
Yeah.
There's the fold, right?
Yeah, right there.
Yep. And then you can also start to work for PLL and do other things.
And then when we say trust the fat, you can see there's fat behind that little plane, right? So that little thing there is not dura, right? You pick that up, right? Remove that, and behind there is going to be traversing nerve root. So.
Perfect. Hey, thank you very much, Sanjay. We're gonna. Is John ready?
Yeah.
You sure you're ready? Because I can do this all day.
So, awesome.
All right, so our next demonstration is Dr. Jon Yoon. He's going to be showing us the biportal technique.
Yeah, let's get
And I think this will be interesting for everybody to see the difference in how your camera view is and how the tools function and how the hands work. So keep an eye on his hands as well. Take it away, John.
Yeah, so I think the biggest difference doing this is that your camera is going to be uncoupled from the tool. So you'll see the motion of my hands versus the tools. That my camera hand is basically going to be looking. It's going to stay superficial to where the tools are. So there's going to be a decouple. And before I get started, this is a off-label use. There's no endoscopic system in the U.S., not yet, that's FDA approved to be used in spine. So everything that we're going to show in this video will be off-label. But who gives a shit, right? We all do off-label stuff every day. BMP is only approved for ALIF, and then we use it every day. So, can I get the spinal needle real quick? Do we have the spinal needle? Okay. Let's just start with the, I have the marking from before. So I'm just gonna go back to the targeting. Let's just take a quick, a shot right here. Okay, so actually that's actually pretty good. We're actually targeting it at the L3-4, so let me just do that. Let's take a shot there. So that's a pretty good localization for the L3-4 decompression. Let's swing to the lateral at this point. And let's take a shot here, because since we didn't show the targeting of the lateral, I just want to make sure that this needle is sitting on top of the facet joint.
So John, you think biportal is a little bit more forgiving than uniportal as far as targeting is concerned?
It is. Yeah. It is a little bit forgiving because you have a play in the system where your tools are not coupled to the camera, so that you'll have a lot more freedom. So this is actually okay. If you look at my needle, I'm right-handed, so my right hand is gonna, the bottom, the caudal end is gonna be my tools, and then my camera is gonna kind of come cranially, and it's converging right at the tip and the top of the facet joint. So from this point, do you have this scalpel? So I make an incision for the tools first. So it's the bottom, I make it in the direction of my tools. I go to the fascia. This part is very similar, and there's a serial dilators. This is the Dual X set that comes, is similar to the metrics, but it has a much smaller diameter to begin. So I usually go in And this is the same thing that Mark and everybody was mentioning, that here you want to feel the bottom of the L3 lamina in this case, and the interlaminar space, and I'm actually feeling all that. I want to dock on the top of the facet joint, my initial dilators.
So for those of you who do percutaneous instrumentation, it's similar. You're kind of palpating with your tools, getting a better idea of where you are comfortable with the anatomy.
Yep. And then the other incision for the camera, which is just a stab incision. You don't want to make this too big because you want soft tissue to be actually holding the scope. So the thing that's also different for the uniportal and biportal is that the biportal camera has the camera's here. So this is a sort of arthroscopy scope. It has a light, and it's just a camera. It doesn't have a working channel. It does not have the irrigation ports. So
what angle camera are you?
This is a 30 degree, but you can use a 0 degree. I often like to use a 0 degree if I'm doing an ipsilateral, like a discectomy is at 4.5. I prefer 30 degrees if I'm going across the midline and doing a bilateral decompression, but you can use either scopes. So this is just a camera by itself. So when you're using this, you still need an irrigation, right? So there's a separate sheath that comes in, and it hooks up to the irrigation ports, and then it allows the water to flow through. So in the beginning, I'm using a sort of, usually there is a sort of obturator that goes inside this thing and then can poke through the fascia, and it goes into the incision. And when I dock here, my tools are already triangulated, and actually tactile feedback, I can actually feel that both tools are converged at the tip. So let's take a shot here.
And while you're taking that shot, do you do anything different with the fascia for managing irrigation for this?
Yes. So I'll show once I turn on the irrigation. Let's turn on the irrigation now. Oops, sorry. Can we turn on the irrigation? Yeah. Oh, yeah. So yeah, this thing has to, so the camera has to fit into the sheath, and then let's turn on the water now. Okay, so I turned the water on, and basically you want this inflow from the camera and good outflow. Right now, the water pressure is not that great. So when I see this, do you have like a Mayo scissors or? So when I see that the water flow is not that great, that means that the water is being stagnant inside this tissue. So I want to open up this fascia up and down so that you have a better outflow. Now let's see the RF probe. So now I have the and then the shield. So now I'm starting to get better outflow. And one thing that you can really help is that this sort of half pipe shield that goes inside the your tool port, and this really keeps the outflow open. So now, I have my camera here. And now my first thing that I'm going to do is trying to find my RF probe. Is the RF probe? Where's the RF probe box? Right here. Okay. So actually would like the coag at 3. So this is a radio frequency probe. This is also different from the uniportal, where you saw that the uniportal RF probe is a very long curved tip. When you press it, it comes out and it looks like a little hook. Because it's a biportal, you can actually use this 90-degree big RF probe, and this is actually quite powerful. So my first thing here is I'm gonna have to find this RF probe, and this is oftentimes the hardest thing about the biportal. So this, I saw the peak of it. So I have the RF probe at, can you put it at the 3, Zach? Oh, it only goes with the 2, okay. So here I'm seeing my tip of my instrument right here.
John, just to clarify, as you're finding that probe, you're working on top of the lamina, presumably, to keep yourself from moving somewhere else.
Well, I can actually feel the bottom of the lamina there. Mm-hmm. And this is the RF probe here, okay? And this is the lamina. So I'm gonna just go a little bit closer. Yeah, so and then you can use I usually have the X-ray kind of draped into my field. So if there's any question, I can take a shot. So imagine right now, what's very different from the uniportal is that my camera is sitting on top of the facet joint, and my tool is deeper, okay? And with my RF probe, I'm actually feeling the lamina here. This is the lamina of 3. Yeah, I'm gonna use a little bit stronger for the time's sake.
You can see how much
And cleaning up the soft tissue. Okay, so here, this is the, I don't know if you guys can see. So this is the lamina of 3, okay? This is the bottom of the L3 here. See how efficient this this RF probe is? This is very powerful. I usually don't use it at this high, obviously in a real patient, but this tool is kind of like your bovie, right? You can actually put right onto the bone. This is the spinous process here. This is the L3 spinous process. This is the L3 lamina. This is the L3 for joint. And then the bottom of the lamina is L3 right here. So let's take a shot here, actually. Let's just confirm that. Oh, actually, we went all the way down. Hold on.
Yep, just about done. Yeah.
Yeah, we
John,
actually
this is great.
went downward.
Would you just show us, in the interest of time, would you show us a little bit, maybe if it's available, just other tools that you might use down this working port?
Yeah, so let me see the, so there is a soft tissue scraper. So, if I don't have a good outflow, sometimes I'll use this. This is a kind of like a cob. You can hold it like this, and actually you can do initial soft tissue work and really try to clean up the soft tissue this way. So you can use that. And do you have a pituitaries? So the tools that we have available, these are the pituitaries. Now you can see that, I don't know if you can see that, once I create this cavity, see how the white
irrigation
outflow, irrigation really comes out pretty well. So the biggest part about the soft tissue handling in the beginning for the biportal is that you want to create this little cavity where the water can go in and really clear out your field and have a good outflow. If you have this really good outflow, then it'll be much easier to identify the anatomy. So
you're essentially creating a nice potential space between those two ports.
Yes.
Deep to the fascia, yeah.
Yes. And then, I think that in the beginning, it's just like the uniportal, where it's hard to, you're going to have a lot of soft tissue and the fat and muscles. So you have to use a lot of tactile feedback to actually find and land on the lamina. But then, I think the soft tissue cleaning is much easier because this RF probe, it kind of works like a bovie. You can actually put this on it, and then this is a much sort of a bigger radio frequency energy field. So it's very efficient at kind of dissecting the soft tissue off the bone. So here, I'm just going to do some little bit more of the cleaning.
John, is there anything else you want to show us? Just in the interest of time, we have to move on to the next demos.
Yeah, so let me actually then do some little bit more drilling. So this is actually the 4-5 right here, the joint. Okay, so let's take a shot. So this is this is a 4 lamina, and then this is the 4-5. So let's take a shot here. Oh, that's a 3-4. Okay, it's a 3-4. Maybe I was a little bit lower. Okay. Okay, so this is the 4 lamina. Let's just make sure again. This is take a shot right here. Is a X-ray here?
I think they got me.
Button. X-ray button.
Yeah. Yeah. So I actually set her a little bit low here. So I'm going to start the bone work, okay? So take a shot here. Okay, so that's centered over the L3-4 facet joint. So what I like to do in the beginning.
Can you hear me? Hey, John, I think because for the interest of time, since you're already here, I think it makes sense to just do some drilling.
Yeah.
And then Kim can get set up for his PowerPoint. But we're already here. You have the drill. You're already set up. Probably easy to just start some drilling right now.
Yeah.
Show us how you drill and what drills you use.
Yeah.
Perfect.
So actually, before I start drilling, I like to point out that the facet joint is here, the lamina is here. I like prepping the facet joint. If I'm doing a fusion, so if I'm doing a facetectomy, I know that this is the top of the facet joint. Mark talked about the multifidus muscles attaching to the bottom here. So I like to prep all this, clean off the soft tissue using an RF probe. Once I have this all prepped, so I'm looking straight at the facet joint. Can I get an osteotome? Do you have an osteotome? You know, I think the advantage of using a biportal, do you have an osteotome? Okay, there it is.
It's not draining. Probably
Do you have a smaller osteotome than this one? Yeah, quarter inch. So I'll show the osteotome later. So I would actually take an osteotome and knock off the IAP from the get-go. Yeah, that's too big. Yeah. Oh, okay. All right, so it's got navigation. So so long. Okay. So let's see the pituitary. It's got some soft tissue here. Just create that track a little bit more. And can you lower the table just a little bit? Yeah, thank you. Okay. Let me see the osteotome now. So what I like to do is once I identify the facet joint, and you can bring in the osteotome, and then could you mallet this? Yeah. Okay, a little bit more. Okay, now take a shot. Okay, went through that. Then make another cut here. That's good. So knocking off that IAP, and let's make another cut. Right here, okay? Take a shot. Yep, that's good. And let's take a pituitary now. So that way you efficiently remove that. I mean, this is how you do it in open, right? Yeah, you can remove that IAP and do a facetectomy efficiently here. Okay. And let me see the RF probe back.
John, can you describe how you're able to use the normal instruments, which is a benefit of advantage of biportal surgery?
Yeah, so I mean, I think the advantage is that this is the facet line here. So SAP is here, IAP is still here. So yeah, I mean, I think it's not quite normal, right? You don't have the Bovie, you have to use an RF probe. But at least the RF probe, the one that we are using here, is kind of acts like a Bovie. It's very powerful. You can use an osteotome. I like using an osteotome. Even though it's possible to use it in uniportal, it's much more difficult. And then, let me see the osteotome back. And then you can use the same pituitaries. The pituitaries are important tools to clean out the soft tissue, and it's much easier to bring it in. So, okay, so this is a residual IAP. Yeah, and then I'll use a drill next. Yeah. And let's use an osteotome again. Yeah, that's good. And let's see the pituitary. So once I have reasonable resection of the IAP, let's bring the drill. So this is a drill that I like to use, and I save all that bone. Actually, let's see the RF probe. This is okay. So here, I resected a part of the IAP. I didn't drill any lamina here, okay? This is the yellow ligament here. Now, what I'd like to do then is bring this drill. So this is the, I don't know if anyone can see, this is a 6-flute, 5.5 millimeter barrel-shaped drill. Yeah, and this is a very aggressive drill bit, right? It's huge, and you can actually fit all this. And this is a reason I like this is that it's got the side sort of protective shield, and it's got a pretty big surface area. So we're operating in a 2D space, so you don't really have a depth perception. So you want your drill to be sort of have a big, large surface area so you can kind of see. So I don't want to go any deeper than that. So I put the drill right there against the yellow ligament, and I want everything above that to drill. So this is a very efficient drill design to take the bone off very quickly. So is it on forward? Yeah. Okay. So, so I'm drilling the IAP here. Okay, and so I'm going to expand that Campbell's triangle. Oh, drill got stuck here. Oh. Okay. So again, I'm going to drill here. The difference between this and then the uniportal is that, yeah, my camera is staying, the camera is staying superficial to where I'm working. So and this is an advantage in my opinion because you can kind of see your drill. And this feels a lot like an open case. And same thing with the drilling when you're doing a uniportal. You want to go in bursts because this does create a bone dust. But when you have a good outflow, you can just drill in burst, and then let the bone dust kind of clear out, and then continue going. Some people do hook this up to a suction, which I'm not a big fan of. Then you can really go through a lot of irrigation bags. So I just let the water kind of come out. So here, I've expanded the window. I haven't done any laminectomy. I've done a IAP removal, which is sort of a transfacet if I'm doing a T-lift. It still have the lamina here, the spinous process in the midline.
John, for the interest of time, could you just quickly finish off the facetectomy and show us this space?
Oh, yeah.
And then we'll move on.
Yes. So you can see that this drill is a very efficient drill, and I'll be able to expose the Campbell's triangles. Okay, so that's the epidural space. Okay, do you have a Wilson? Let's actually use a Wilson to dissect now. So that's probably a yellow ligament. Yep. Okay. So you can use the regular tools here. So if I have a Wilson, I like using a Wilson to kind of dissect. And do you have a Kerrison number 4? Move that out of the way. All right. So let's use a Kerrison. You can take off the rest of the facet joint here. Do you have a Kerrison number 5? Or is that the 4 is the biggest one? Oh, 3 is the biggest. Yeah.
So you have disconnected the IAP and SAP at this point,
yeah, so
correct?
this is actually, I can feel this is the pedicle of 5 here.
Gotcha.
I said pedicle of 4.
Yeah.
So
we'll see you take off that bone, and then we'll move on.
Yeah. Oh, 4 is here? Okay. Let's use a 4. Okay. So you take off that facet joint, and I'm going towards the foramen here.
Yeah, all right.
And you can see that, this is exposing the Campbell's triangle here. And do you have a Wilson now?
Gotcha. All right, so we'll finish up the rest of it in the lab. Let's go to the PowerPoint. Thank you, John.
Yeah, thank you. So this is the...
Thank you, everyone, for having me.